Hi, how are you?
I'm good. How are you?
Oh, it's my Friday, so
That's a nice thing.
it is. We can all see the full screen again.
Yep.
Perfect. All right, I'm just gonna get started, even though it's a small turnout. So welcome to this quarter's Quality Improvement Committee meeting. I appreciate everybody taking the time to come. So this meeting is being recorded. I'm going to go off camera just for my bandwidth. This meeting is being recorded. If you do not wish to be recorded, you may leave the meeting. The video will be posted on the MHSA YouTube channel as well as on the County of Lake Public website. Excuse me. All right, so we're going to start with the network adequacy audits. For the fiscal year 21-22, the NACT for NACT, DHCS granted LCBHS a conditional pass as the entire audit was in compliance with the exception of 2 points. Those 2 points were insufficient psychiatric provider capacity for adults and insufficient psychiatric provider capacity for children and youth. DHCS required us to complete and submit a corrective action plan, also known as a CAP, detailing actions to immediately implement and ensure compliance with these requirements. LCBHS increased the fiscal year 21-22 contract with the North American Mental Health Services, also called NOMS, to fulfill these requirements and submitted that CAP in March 2022. In April of this year, we were given a rating of compliant from DHCS on the fiscal year 21-22 NACT. And the fiscal year 22-23 NACT, was completed by the compliance team and submitted to DHCS on August 29th, 2022. So for grievances and appeals, I know we talked about these in the last QIC. However, I just want to bring everyone up to date. Fiscal year 21-22, we had 18 grievances and all were resolved within the required 60 days. The primary grievance topics were quality of care, medication concerns. Those are the top 2 big ones. And then a large mixture of other, which included contestation of FSP termination, DUI charges, refunds, and stuff like that. For this current fiscal year in Q1, we have 2 open grievances and both are for medication concerns. Does anybody have any questions or? Okay. So for the conserved clients update, I know we had an update last meeting with some exciting stuff, a lot of people being brought back to county and stepped down from higher levels of care. So just to break those down, in August, they stepped down 1 client from a locked facility to a residential treatment facility. 2 clients were moved from out of county placement back to Lake into Manzanita House, which is exciting, and moved 1 client from placement out of county into independent living back in our county. So that's awesome that people are doing so well. Upcoming next month, the team is preparing to bring 1 client home to Lake County and into Manzanita House. So that's basically the overall goal, bring everybody down from higher levels of placement and back into our county so they have more supports. So the DMC ODS implementation plan was submitted to DHCS on August 1st of this year. We received a notice of disapproval from DHCS, received this month on the 7th. We worked directly with partnership to incorporate revisions and corrections, and the revised implementation plan was resubmitted on 9/20 of this month. Key stakeholders being identified. The meeting was scheduled to take place after submission of implementation plan and prior to the memorandum of understanding. We are currently resolving the 2021-2022 caps for clearance and entering ODS. Does anybody have any questions? I know Rob's here if there's any questions on that.
This is Michelle. I had just out of curiosity. So what are our caps for clearance?
The
Since
caps
it's-
for clearance are anything for fiscal year 21-22, 2021, any corrective action plans that we have for our audits on
Mhm.
substance use,
Uh-huh.
any of the findings that DHCS found for us. So it could be something as simple as we didn't have in our contracts or our policy statement saying that we will not promote drugs. There's a mandate, there's a law that says any funding that is received off of a grant, you can't promote drugs off of Schedule 1, I think. So we can't promote marijuana, we can't promote meth, we can't promote anything related to drugs. So we have to put that in our contracts with our providers, and we have to have have that in our policies. So that was a corrective action plan.
Okay, awesome. Thanks.
So-
Thank you,
Was that-
Rob.
That was great. Thank you.
Okay. The DMC ODS implementation plan continued. The readiness review required when opting into regional model is to be conducted. Partnership is going to conduct the network adequacy certification, and that's certified approximately 6 months before it goes live. We're meeting bi-weekly with partnership, Rob, to review implementation steps and updates.
Yeah.
Okay, and July 2023, we will go live with it.
Yay.
Yay. All right. So, buckle up. These are super fun slides. These are the performance outcome measures. We are now using what is called HEDIS measures, that stands for Healthcare Effectiveness Data Information Set. Using HEDIS, using HEDIS measures to improve healthcare outcomes. It will improve coordination between the managed care plans and the specialty mental health plans and drug Medi-Cal plans, and improve client outcomes. DHCS has selected 3 HEDIS measures to track plan performance. The FUM, which is follow-up after emergency department visit for mental illness. The FUA, which is a follow-up after emergency department visit for AOD. And the POD, which is pharmacotherapy for opioid use disorder. And we'll get into each one of these individually with our benchmark percentages. But first, VHQIP HEDIS measures timeline. Right now, we're in the discovery phase, which is to inform the development of the PIP plans, the performance improvement project plans. DHCS has provided the VHQIP county-specific performance measures in July 2022, and the measurement periods were calendar year 2020 and calendar year 2021. This report, the one that I'm going to take from in the next slides, references calendar year 2021 data. The next phase is the baseline phase, which will kick off in March of next year. Cal Mesa will work with the counties to recalculate these measures by linking county mental health plans, service data, and drug Medi-Cal data to managed care plan and pharmacy data for fiscal year 21-22. This is the baseline that will be used to measure progress on these measures. And then the final phase is the progress phase, looking ahead to next September. So a year from now, Cal Mesa will work with counties to calculate these measures for fiscal year 22-23, including quarterly performance to measure change in the measures since fiscal year 21-22. So what are the goals for using these measurements? So the goal overall is to meet the 50th percentile national benchmark and then exceed it. So basically your lowest goal is 50th percentile. And then you want to aim for excellence, which is defined as reaching the 90th percentile national benchmark. So what does this mean for individual counties? It means we are on an incremental improvement to meet the 50th percentile national benchmark or it should be and, or exceed the 50th percentile and move toward the 90th percentile benchmark. DHCS said that they cannot accept the 50th percentile or average as our goal. This foundation must be coupled with opportunities for incentives that can support local innovation and transformation efforts and achieve our vision of achieving greater than the 90th percentile on key measures or excellent care across programs. So basically it just gives us a numerical percentage to, so we can visualize how well we're doing with our outcomes for each of those 3 measures. So let's start with the FUM, the follow-up after ED visit for mental health. There is a formula. It's split into FUM 7, which is within 7 days, and FUM 30, which is within 30 days. So it's basically the number of mental health services within 7 days divided by the number of emergency room visits for mental illness, and then the same thing for the 30 days. Basically, the interpretation of this is among Medi-Cal beneficiaries, X percentage of emergency department visits with a mental health disorder principal diagnosis were followed by a connection to mental health services within 7 or 30 days. Okay. So here's our comparison to the national benchmark as well as California. So for this one, we're doing really well. In 2021, 55% of emergency department visits for mental illnesses were followed by a connection to mental health services within 7 days, and 63% within 30 days. So for this one, we're already well above that 50% initial goal. So now we're on our way to the 90. Okay. So this puts Lake County above the national and California benchmark. So hooray for us. So for the FUA, the follow-up after emergency department visit for AOD, it's the same type of structure, but it's the follow-up service for substance use service within 7 days, divided by the number of emergency department visits for AOD. And again, the interpretation is among Medi-Cal beneficiaries, X percentage of emergency department events with an AOD principal diagnosis were followed by a connection to mental health services within 7 or 30 days. So this one's not as happy as the FUM one, but we have room for improvement. In 2021, 7% of emergency department visits for substance use were followed by a connection to substance use services within 7 days, and then 15% within 30 days. This unfortunately puts Lake County below the national benchmark and right on par with the California benchmark. So we definitely have room to grow, room to improve as we go along for this next calendar year. So the last one is the POD, the pharmacotherapy for opioid use disorder. This one is just one thing. It's not split into 7 or 30 days. The numerator is number of medications for new opioid use disorder for 180 plus days without a gap, divided by the number of initiations for the medication for new opioid use disorder. The interpretation of this is that among Medi-Cal beneficiaries, X percentage of MOUD initiations continued the opioid use disorder pharmacotherapy for 180 or more days without a gap in treatment. So this one, in 12% of medication of opioid use disorder initiations, the beneficiary maintained opioid pharmacotherapy for 180 days without gaps. This puts Lake County below the national benchmark and above the California benchmark. Does anybody have any comments or questions about this? Or good, April?
Actually, any data or any information that you could send me in a separate email would be appreciated, so I could help work on performance improvement plan for this.
For sure. Thank you. Okay. Is Matt here yet? But I guess Michelle is also here. So Michelle, do you want to I know Matt was going to do these slides, but I don't see that he's here.
Yeah. So
There's-
sure, I guess. Or is he here now? No.
I don't see him. I knew that he
Okay.
was, yeah.
Okay. So yeah, so LCBHS has entered into agreement with Cal Mesa to create to be a part of the semi-statewide electronic healthcare record. So this was the genesis of this was have been using our current EHR for a very long time, since before I started working for LCBHS, and it is called Anasazi. And it is quite antiquated. It is set up in a modular way where it's very difficult with a lot of tables to access the data that we need. So, and plus Anasazi will be sunsetting sometime in the near future. So Cerner, who is the vendor of Anasazi, had started to create a new EHR called Millennium, or Cerner Behavioral Health. And we looked at it and joined into an agreement with Cerner to use this. And as we moved forward with the project, we just realized that it wasn't going to meet our needs. We tested it quite a bit, and it was really lacking in the state reporting, and our state reporting needs, and as well as our substance use disorder needs for client support. So we just said, no, we're backing out. At that point, we began a new EHR process, new EHR selection process. That was some of the management team, my boss, Elise Jones, and I started to work on this. And if you could move to the next slide. And so while we were doing this, we had previewed several different vendors and their EHRs. Cal Mesa came out with this opportunity for the semi-statewide enterprise health record. And what this is, it's a standardization for California counties in their EHR. So we were pretty excited about it, not only because of the standardization, but also because of the cost. You know, that being part of this consortium has lowered the cost for us. So we discussed it and decided to join this consortium and this agreement. And when we did, we were selected as a pilot county, which is pretty exciting because we get to be one of the first counties to get this going on our network and with our staff. And so as luck would have it, Cal Mesa sent out their RFP to vendors for the new EHR. And one of the vendors that Elise and I had been looking at and really liked was Streamline Smart Care. And that happens to be the vendor, the EHR that Cal Mesa selected. So we're currently working with Cal Mesa to get this up and running. Smart Care EHR, it's truly enterprise. It's cloud-based, so we don't have to have all the extra equipment and monetary concerns about supporting a server and maintenance of that and equipment costs and such. And it meets that the EHR itself meets so many of our organizational needs, like full clinical care management. This includes mental health and SUDS. It's a golden thread among all of those processes within, or the workflow within those two environments. We can still, according to 42 CFR, keep them individually and confidential as needed, but we can also, you know, as we progress into the ODS, we can also combine those services. It also has a revenue cycle management, which is our billing. We do have that now currently with Anasazi, but this will allow us to be more closely involved with the reporting of cost reports to the state. So, and then business analytics was one of the biggest pushes for this, because it is on the fly real-time data that we can pull out of our system, and anybody can do it. Really, any user can do it. So I'm really excited to be starting to test all of that. We will have e-prescription, which we already do, and a patient portal, which we don't have. And initially, this will allow the patients to access our EHR from their desktop, their phone, any kind of their iPad, whatever, and look at the records and look at their scheduled appointments and be in touch with us that way. That will progress and move on as we become more involved in this, and we hope that that will be also include sending out reminder texts and reminder calls to patients about when they have their next appointment. So it's going to be very interactive, and I'm pretty excited about that too. We are the business software analyst team, and I are currently working with CalMesa, their technical teams, to prepare the new EHR for use. We're sending them documentation on how our tables and our service codes and our procedure codes are set up. CalMesa is working very, very closely and very, very rapidly with SmartCare to create a testing environment. And that is due to us within the next couple of months. I actually think that we'll get it sooner than that. The sandbox, which is where we get to go in and play. I call it playing. We'll get to go in and navigate the new EHR and see how the work flows and start deciding on our workflows. That's supposed to be coming down in the next, I think within a month. And then again, they are actually starting migration tomorrow, but that doesn't mean the data is going to be moved tomorrow. That will start in the next couple of weeks, but they'll be setting up all the data modules and such like that. That'll all be starting tomorrow. Our go live date for this is February 1st, 2023. And we're really on track. I don't see any barriers to that not happening. It's really an aggressive timeline, but we're here to do it, and we're really excited to be a part of this pilot program. Thanks.
Awesome. Thank you so much. That was awesome information. I really appreciate it, Michelle.
You're welcome.
So does anybody have anything to add or would like to see in December on our next QIC? You can always email me, kate.lewis@Lake County.ca.gov if you have anything to add, or give me a call. And I appreciate everybody joining us for this meeting. The next QIC meeting will be held on Thursday, December 15th at 10 a.m. The agenda and Zoom link will be sent out in November. I'm going to take that process back over and send out an actual invitation for your Outlook calendars, so it's a little bit easier to remember. And we hope to see you there.
Thanks so much, Kate.
Thank you.